You walk into the bathroom every morning. You open the medicine cabinet. There are 5, maybe 7 bottles on that shelf. Some of them are prescriptions your doctor wrote. Some are the ones you picked up at the drugstore without ever thinking of them as medications at all. The little pink pill for allergies, the blue soft gel for sleep, the one you started for your bladder, the one you take for the anxious moments before an appointment. You do not think of that shelf as dangerous. You think of it as help. But something else has been happening. Words have started to catch on the way out. A name you have known for 40 years pauses somewhere between your brain and your mouth. You walk into a room and stand there. What did you come in for? You read a paragraph, and at the bottom, you go back to the top, because none of it stayed. You wake up in the morning, and it takes an hour before your mind feels sharp. An hour it did not use to take. You have been telling yourself, this is age. The research published in JAMA Internal Medicine says it might not be. Daily use of certain everyday medications, the ones on the shelf you just opened, the ones your doctor wrote and the ones you buy over the counter, raised the risk of developing dementia by 54%. 63% for Alzheimer's disease specifically. That is not from decades of use. That is from about 3 years of daily use across a decade. 9 drugs sit at the center of this finding. 6 of them are almost certainly on your shelf right now. And by the end of this video, you will know exactly which one is number 1, the drug that millions of seniors take every single night without ever thinking of it as a drug at all. Stay until number 1. Number 1 changes how you look at that medicine cabinet forever. Every week on Inside Aging, we go through the prescribing research your 15-minute appointment does not have time to explain, including the drug interactions the current medication review process was not built to catch. Before we go any further, I want you to do something. Grab a pen or open the Notes app on your phone, because in the next 60 seconds you are going to give yourself a number, and that number is going to belong to you. There are 5 signs the research has connected to the drugs we are about to discuss. Score yourself on each one, 0 to 3. 0 means never. 3 means most days. Sign 1, the word that will not come. In the last week, how often have you paused in the middle of a sentence, knowing the word, unable to reach it? Sign 2, the room you walked into. How often in the last week have you stood in a doorway trying to remember why you came in? Sign 3, the paragraph you read twice. When you read something, a magazine, a book, an email, how often do you have to go back and reread because it did not stay? Sign 4, the familiar name that blanked. How often in the last week has a person's name, someone you have known for years, refused to come? Sign 5, the fog before breakfast. How often do you wake up and feel cloudy in your head for more than an hour before your mind clears? Add the 5 numbers, that is your score. 0 to 3, the research would call age-appropriate variation. 4 to 7, that is a signal worth taking to your doctor with the list we are about to build. 8 to 11 is elevated. 12 or higher, and a medication review comes before any other workup. Post that number in the comments right now. Just the number, nothing else. In 14 days, after the conversation we are about to prepare you for, you are going to retest, and you will have proof of what changed. Here is the part that rarely comes up in the appointment. Your primary care doctor sees one of your medications. Your urologist writes a different one. Your psychiatrist writes a third. Your orthopedist added the muscle relaxant after the fall 2 winters ago, and you bought the sleep aid at the drugstore last month. Each of them looked at their own drug and said, "This is safe in your dose." In isolation, each of them was right. The problem is the pile. The current system was not built to add up what 4 different specialists prescribed, plus what you bought over the counter. If this is landing for you, if you are looking at your own medicine cabinet a little differently right now, take 1 second and tap that like button. When you do, YouTube shows this to thousands of other people over 65 who are quietly noticing the same fog and blaming their age instead of their pills. You could be the reason someone's father catches this before the damage sets in. So, what are these drugs actually doing? There is a chemical in your brain called acetylcholine. Most people have never heard of it, but it is the single most important chemical your brain uses to lay down new memories, to hold your attention on what someone is saying, and to pull a name up out of the archive when you need it. Acetylcholine is the ink in the pen your brain writes memories with. The drugs we are about to discuss share one hidden property. They all block acetylcholine. They do not destroy the pen. They take the ink out of it. In the short term, the pen still moves across the page. The writing just gets fainter. You still function. You still get through the day. But the memory of the day does not fully land. Do that for weeks and you have brain fog. Do it for months and you have trouble finding words. Do it for 3 years of daily use across a decade, the exact threshold in the gray research from JAMA Internal Medicine. And the numbers say you have a 54% higher risk of developing dementia. A separate UK study of 284,000 adults, published 4 years later, found nearly the same signal, a 49% increased risk of dementia at high cumulative exposure. 2 large studies, 2 continents, the same conclusion. And there is a third finding that startles most doctors when they see it. When researchers ran brain MRI scans on cognitively normal older adults taking anticholinergic drugs, they found measurable brain atrophy, actual shrinkage in memory-related regions, compared to non-users. Not symptoms, structure. One more piece of biology, because this explains why the same pill affects a senior differently than it affects their 40-year-old daughter. 3 things stack with age. First, the brain naturally produces less acetylcholine. There is less ink to start with. Second, the blood-brain barrier, the wall that keeps most drugs out of the brain, thins with age. More of the drug gets in. Third, kidney and liver clearance slow, so the same daily dose stays in the body longer. Same drug, same dose, 3 times the impact. Most seniors, when this gets explained, immediately guess the villain is the antidepressant, or the sleep prescription, or the anti-anxiety pill. It is not any of those. The single most consequential drug on this list, by an enormous margin, is a drug you can buy at any pharmacy without a prescription. Costs $8 a bottle. You have taken it since your children were small, and you do not think of it as a drug at all. It sits at number 1. Stay with me. Let me tell you about a case that shows up again and again in the anticholinergic literature. A man named Thomas, 68 years old, retired accountant, sharp his whole life, the kind of man who did the crossword every Sunday in ink. He came to his doctor's office because his wife had started asking him things twice. He had thought she was repeating herself. She had thought he was forgetting. His medication list looked ordinary. A blood pressure pill, taken since he was 52. A low-dose antidepressant his doctor had added 5 years earlier for a rough patch after his brother died. A muscle relaxant from an orthopedist for chronic back pain. A prescription for his overactive bladder. His urologist had written it 3 years earlier. A drop from his ophthalmologist. An allergy pill his primary doctor had suggested for seasonal congestion, and an over-the-counter sleep aid he had been taking almost every night for 6 or 7 years because his wife snored and he could not fall asleep without it. 7 drugs, each one from a different doctor. Each one, in isolation, appropriate. It had never been reviewed as a single list. When a geriatric pharmacist finally ran the numbers, Thomas was carrying an anticholinergic cognitive burden score of 9. The threshold for clinical concern is 3. They tapered the sleep aid first, then the bladder drug, swapped for a newer class that does not touch acetylcholine. Then the antidepressant was switched to one with far lower burden. Within 6 weeks, the crossword came back. That is not a miracle. That is what happens when the ink comes back into the pen. Let me clear a few things up, because some myths get in the way of this conversation. Myth number 1. If a drug is sold over the counter, it is safe. False. Diphenhydramine, the active ingredient in most PM pills and most over-the-counter sleep aids, has been on the American Geriatric Society's list of drugs to avoid in adults over 65 since 1991. Being sold without a prescription is a marketing decision. It is not a safety statement. Myth number 2. If the fogginess goes away when I stop the drug, no harm was done. Not quite. The daily fog reverses in days. The long-term dementia risk from years of cumulative use, at the highest exposures, appears to persist even after the drug is stopped. The daily symptom and the long-term risk are two different things. You can lose one and still be carrying the other. Myth number 3. My doctor would have told me if this drug was dangerous. Not necessarily. Your doctor sees 15 minutes of you. They look at their prescription in isolation. Anticholinergic burden is a sum. It requires someone adding up prescriptions from 3 or 4 different doctors, plus whatever is on the pharmacy shelf. That role does not exist in the current appointment structure. Now let us look at exactly what is on that shelf. Number 9. Cyclobenzaprine, sold as Flexeril. Prescribed for muscle spasms and back pain, usually short-term. The problem is, it rarely stays short-term. It is chemically related to the older tricyclic antidepressants, which sit near the top of the anticholinergic burden scale. Number 8. Tolterodine, brand name Detrol. Prescribed for overactive bladder, same drug class as the more famous version, oxybutynin, which is coming later on this list. All of these bladder drugs cross into the brain because acetylcholine is what controls both bladder contractions and memory formation. Block it in the bladder, you block it in the hippocampus. Both are running on the same chemical, and the drug cannot tell them apart. Number 7. Amitriptyline, Elavil, Endep. It is an old tricyclic antidepressant that most doctors will not prescribe for depression anymore because newer drugs work better with fewer side effects. But here is where it hides. Low doses, 10, 20, 25 milligrams, get prescribed for nerve pain, for chronic migraine prevention, and for insomnia off-label. Seniors take it and forget it is an antidepressant at all. It is still on the same burden scale as if you were taking it at a full dose. Number 6. Oxybutynin. Brand name Ditropan. This is the drug that put the anticholinergic dementia link on the map, because it was one of the most studied compounds in the original Gray research. If you are on oxybutynin for bladder control and you have noticed cognitive changes, the immediate release form is the version that crosses into the brain most freely. The extended release version and the skin patch have less brain penetration. That difference is worth asking your doctor about. Number 5. Hydroxyzine, Vistaril, or Atarax, prescribed for anxiety, itching, insomnia, and pre-surgical sedation. It gets recommended as the gentler alternative to benzodiazepines. That is true for addiction risk. It is not true for cognitive burden. Hydroxyzine sits at the very top of the anticholinergic scale. Number 4. Chlorpheniramine. This one hides. Chlorpheniramine is a first-generation antihistamine, same family as diphenhydramine, but you rarely see it named on the front of the box. It is inside multi-symptom cold medications like Coricidin, and inside older combination products. Picture the 70-year-old who catches a cold every March and takes a combination cold and flu tablet 3 times a day for a week. She thinks she took cold medicine. Her cognitive burden that week went up by 3. The second-generation antihistamines, loratadine, cetirizine, fexofenadine, do not meaningfully cross into the brain. That single switch cuts cognitive risk enormously. Number 3. Doxepin, brand names Sinequan and Silenor. Here is a nuance that matters. Low-dose doxepin, 3 or 6 milligrams for insomnia, has minimal anticholinergic activity because at that dose it works through a different receptor. But at 25, 50, or 75 milligrams for depression, it lands solidly at the top of the burden scale. Same drug, different doses, very different cognitive risk. Number 2, paroxetine. Brand name Paxil, an S3 antidepressant. This is where most seniors are surprised, because SSRIs are usually thought of as the safer, modern class. That is true for most of them. Sertraline, escitalopram, citalopram all have low anticholinergic activity. Paroxetine is the exception. It carries the highest anticholinergic burden of any drug in the SRI class. The Beers criteria specifically names paroxetine as a drug to avoid in seniors. If you are on Paxil, ask your doctor about switching within the same family. The transition is usually straightforward. And number 1, the one that changes how you look at that medicine cabinet. Here is what makes number 1 different from every other drug on this list. It is not that it is uniquely powerful. 5 of the drugs above are stronger anticholinergics on a milligram for milligram basis. The most dangerous part of number 1 is not that it is powerful, it is that millions of people do not even count it as a medication. Diphenhydramine, also known as Benadryl, also known as the PM in Tylenol PM and Advil PM, also known as ZZ-Ziquil and Unisom, also known as the little pink pill for allergies, also known as the blue soft gel that helps you sleep. One drug, a dozen names, sold over the counter, without a prescription, for $8 a bottle. An estimated 1 in 3 Americans over the age of 65 takes it at least monthly, mostly for sleep. It sits by more nightstands in this country than any other sleep aid, prescription, or over-the-counter. Every night you take it, you are cutting the ink to the pen your brain uses to hold today's conversations, today's tasks, today's names, today's paragraphs. In the morning, some of that comes back. Enough that you do not notice. But the research is now clear. The cumulative version does not fully reverse. It does not appear on the medication list at the doctor's office. It does not appear in the pharmacy record. It does not appear in the electronic health chart. Which means the specialist reviewing your other prescriptions has no way of seeing it, and no way of factoring it into the burden. That is number 1. That is what changes when you look at that shelf tonight. Here is the number most people over 60 never hear. The Beers criteria, the American Geriatric Society's official list of drugs to avoid in adults over 65, has flagged first-generation antihistamines like diphenhydramine as inappropriate in seniors since 1991. 35 years ago, an entire generation of geriatric doctors has known this. An entire generation of pharmacists has known this. It has been in every textbook. 35 years, and most seniors taking these drugs today have never once been told. That is not a story about hidden research. That is a story about a gap between what medicine knows and what makes it into the 15-minute appointment. Take a second right now and write your age in the comments, just the number. Because here is why age matters for this specifically. The cognitive changes from anticholinergic drugs are dose-dependent and time-dependent. Every year you keep taking them at your current burden, the load compounds. But the reversibility of the daily symptoms and the pause on further cumulative damage begins the day the burden comes down, not 5 years from now, not after some tipping point. The day you and your doctor start subtracting. A person who catches this at 65 has more to gain than a person who catches it at 75. A person who catches it at 75 has more to gain than a person who catches it at 80. Your age tells you exactly where the leverage is. Here is exactly what to do. The Medicine Cabinet Audit, 5 steps, tonight. Step 1. The shelf inventory. Pull every bottle off your bathroom shelf, every prescription, every over-the-counter, every vitamin. Line them up on the counter. Photograph them if it helps. Step 2. The cross-check. Compare each name to the list of 9 you just heard. Circle the ones that appear. If a product name is not on your list, a Tylenol PM, an Advil PM, a Coricidin, a NyQuil, a ZZZ quill, a Unisom. Read the active ingredients on the back of the box. If diphenhydramine, chlorpheniramine, or doxylamine is listed, that product goes on your circled list. Step 3. The burden count. Count how many circled bottles you have. If the answer is 1, you have a conversation. If the answer is 3 or more, you have a burden problem the current medication review process has not caught. Step 4. The appointment. Book 15 minutes with your primary care doctor, or, if you have access to one, a geriatric pharmacist or geriatrician. Bring the photograph. Ask one specific question. Is there a lower burden alternative for any of these drugs? Not whether the drugs are working, whether a swap exists. There almost always is one. Step 5. The retest. 14 days after any change your doctor makes, come back to this video and run the 5-symptom checklist again. Post your new score in the comments right below your first one. If your number came down, you now know what was quietly happening and what to do next. One warning that matters: do not stop any of these drugs on your own. Some of them, the antidepressants especially, paroxetine and amitriptyline, require a taper. Stopping them abruptly can cause withdrawal symptoms and can be dangerous. This is a conversation with a doctor, not a solo decision. Always consult your doctor before starting, stopping, or changing any medication. One service worth asking about: comprehensive medication review. Some pharmacies now offer a formal one-on-one appointment with a pharmacist who runs your full list through an anticholinergic burden scale. Medicare Part D covers it for most enrollees taking multiple medications. Ask your pharmacist. If they do not offer it, ask which pharmacy in your area does. It is one of the most useful and least used services in senior care. This is not a story about panic. It is not a story about throwing out your medications. It is a story about a shelf in your bathroom that has been quietly doing something you were never told about. And about the fact that, from tonight, that stops being invisible. Go back to the number you posted in the comments earlier. That number is a starting point. In 14 days, after the conversation with your doctor, after any swap that gets made, that number is going to move, and you will have proof of what was possible. Inside Aging exists for one reason: to give you what the 15-minute appointment does not have time to explain: the research, the prescribing gaps, the interactions the system was not built to add up. Subscribe now, and every week we go through another one of these: the drug, the sign, the study, and exactly what to do with it. Hit the bell so it lands in your feed the day it goes up. And if you know someone over 65 who is on a stack of medications and quietly noticing the same fog you were before this video, send this to them. Not because it will help this channel, because it might save the crossword. We will see you next week.